Hello friends, it's Dr. Russ. Here is a treatment video for you to enjoy. In this one, I'm working with Elle. She's 36 weeks pregnant and has had a pretty uneventful pregnancy other than stress fatigue and lower back and hip pain, which we've been able to help with all of those things, working about once a week or every 10 days, depending on her schedule. A couple things I forgot to mention in this video because I just kind of got so into explaining what I was doing in the moment. One is that my table is not a drop table, but the thoraco-abdominal piece does lower to make room for the belly of a pregnant person to lay comfortably prone, which is really wonderful. The other thing is how important it is for successful delivery and comfortable pregnancy to have good tone and health of the pelvic floor. So that's outside the scope of what this video is showing, but it's something that we'll do in a future video and talk about pelvic floor health for men and women. It's very important, as well as the health of the hip joints and the deep rotator muscles of the hips. All of those things being in good tone and flexibility is really helpful for a comfortable pregnancy and an easy delivery, which everybody wants. So I hope everyone does enjoy this one and more to come soon. So enjoy. Hi, it's Dr. Russ. Today we're working with Elle, and as you can see, Elle is wonderfully pregnant, I think 36 weeks.
36 weeks.
36 weeks. And so we've been working on hip stuff and low back stuff, which very commonly there's discomfort with pregnancy. As you can see, the shape of the body changes, and actually come step forward a little bit right there. And we get, as the uterus and the abdomen distends forward, there tends to be a hyperlordosis and a hyperextension in the lower back. So we work on keeping those lower back muscles pliable and free to move with good circulation. We make sure the discs don't get irritated. We make sure the sacrum is nice and mobile. We work through the hips. So she's been doing really well. A little bit of pain here and there. But now suddenly the pain has gone down more into the calves, and also tension in the upper body just from having to reach around the belly in order to do the dishes and childcare and things like that. So I should say this has been a great pregnancy, really healthy, even though working full time and having a toddler at home. So it's really challenging, and you've worked really hard, and you've done really well.
Oh, thank you.
You're welcome. So we're going to have you lay face down, and just this table, the thoracic piece comes down so that we can accommodate the tummy. So let's get you ready. So we've got her comfortably prone, and just a gentle initial scan looking at the calves. There's no swelling. Nothing looks wrong. Everything's fine. So my first instinct when she said that she was starting to have pain down the legs is okay, is that sciatic nerve stuff. And so I asked about numbness, tingling, sharp shooting pains, and that there was a no to all of that, right, Elle? And so my next thought then is just tension down that superficial back line of the leg. So if we look at, here's her ischial tuberosities right here, the sit bones, and the hamstrings connect here, and then through the sacrotuberous ligament right into the sacrum here at the sacrococcygeal junction. So all of this down to the hamstrings and into the calves, around the heel and to the toes. That's one fascial line. And we can break that up into distinct tissues, that sacrotuberous ligament, the hamstrings, the gastrocsoleus, the Achilles tendon, and then the plantar fascia, but it's all continuous. There's no interruption to that. So I believe, at least initially, that probably what we're looking at is some tension from forward tilt of her sacrum being translated right down into the calves. So in order to address this, we're going to work the calves and loosen them up a little bit, give them a little blood flow and relief, and then we're going to do what we always do when Elle comes in, which is make sure that the sacrum is in a good position and the sacral fascia is nice and mobile. And then we'll work our way up through the rib cage and get her shoulders loosened up as well. How's that sound?
That sounds great.
Good. And again, I don't think the root of the problem is here, so we're not going to spend a ton of time But we definitely want to check in, make sure that initial kind of very brief palpation didn't miss anything really important. Good. So when I'm down here in the calves and the feet, there can be a lot of tenderness here. So I want to kind of keep an eye on the patient's breathing. While I do this, if I start to hit something that's tender, usually people will hold their breath. And so if I see that happening, then I know I want to lighten up. So with my bottom hand here, with my left hand, I'm just inducing a little eversion dorsiflexion. You can get a little bit of a stretch through the Achilles as I'm kind of stroking up along the gastroc. Just getting that counteracting movement. So it's not really an Achilles or a calf stretch, but it is a mobilization and a gentle myofascial release. So focusing more on the medial, focusing more on the lateral, and then coming straight up the middle just like that. And let's see how it responds to a little stretch. Okay, so just a full dorsiflexion of the foot. Elle, I want you to try not to help, okay? There you go. That's better. Does that hurt? Nope. Feel a little bit of a stretch? Yep, that's good. It's good range of motion, nice end feel, no problem there. Let's shift over to the left side. All right. So same idea here on the left side. Feels good. Good. Elle, what's your due date?
September 19th.
Really soon. And do you have a last day of work?
No, I'll be working all the way up to
Straight up to the day. Dedication. Same idea. Just a little traction, dorsiflexion to eversion through the ankle while I stroke up the calf. Good. This definitely is very direct, but it's not pokey. You just want to make sure we're getting in there and moving those tissues gently and in the right direction. Okay. So far, so good. You're going to let me lift this one, okay? No helping? Good. Wonderful. There you go. Good. Nice smooth dorsiflexion, good range, nice end feel. Okay, your calves are good. That's good. Okay, so we come up here and let's look at the pelvis from behind. And we're just going to outline what's where. So I've got her sacrum here, the ish tube here and here, the coccyx here. And so we're going to do all this palpation through the shorts, find the lateral border of the sacrum, the lower SI joint on the left, and the lower SI joint on the right. And those are nice and even, both in the front to back plane and the up to down plane. So as far as pelvic torsion, I don't think that any exists right now. But what we do have is that forward flexion of her sacrum, which is tending to bring all the fascia up with it. Okay, so that's all being caused by the changing shape and center of gravity in the abdomen, which is a normal, healthy part of pregnancy. And we can't and don't want to undo that. But what we can do is make sure that all this fascia doesn't get stuck in this wrong position. So we're going to work that sacral fascia and the SI joints and then just the top of the glutes. Okay, so we've got some nice mixture of oil and shea butter on the skin. And we've been working about every 10 days or so for the last 4 months or so, maybe. And so things are in good shape, and there's not a lot of really stuck tissue. So what I've got here is 2 fingers down, and you can see the whiteness of my nails that I'm definitely using some pressure, and I'm just supporting that with my other hand, and I'm putting inferior pressure along the sacral apex like that. So I'm sort of engaging with the bone, but mostly on the thick, dense, deep fascia between the fatty layer and the bone, that deep fascia. That sacral fascia is so important. It blends with the sacroiliac ligaments, so it influences the position of the SI joints. It blends with the sacrotuberous and sacrospinous ligaments, so it has a lot of influence over the hips and the relationship between the hips and the pelvis. So coming deeper with the pressure and then inferiorly along there, just to make sure that things don't get stuck. Because ideally, after baby is delivered, there's nothing impeding the pelvis from returning to healthy biomechanical position. We don't want it to get stuck in the position that it's in right now. So let's do her left side of the sacrum. Same idea. And 2 fingers coming deep, stabilized by the other hand, and pushing down and toward the feet. Pushing a little toward the floor, mostly toward the feet. It's a nice deep stretch. So here I just changed. I'm using my thumb because the tissue is a little thicker right there. And I want to make sure that I use what's going to give me the greatest advantage, because I do want to be able to do this all day. I don't want to tire myself out on her. So I'm going to raise the table up a little bit. And let's work these thoracic paraspinals, thoracolumbar fascia. Gentle, nice deep breath here. Good. Beautiful. So as I'm feeling the lumbar spine on my patients and I ask them to take a deep breath, I'm really looking for it. Take a deep breath again to rise up toward the ceiling and lengthen a little bit. It almost looks like a loaf of bread that's leavening on a time lapse. That's the normal movement of the thoracolumbar spine with an inhalation. Is it lengthens a little bit and it rises toward the ceiling a little bit. Hers moves really nice. But I'm feeling here on the right side, little bit of tension here is that serratus posterior inferior and a little bit these thoracolumbar erectors. So you can really see, if you think about the transverse abdominal and the external oblique muscles that are kind of like this, becoming a sling for the abdomen as the abdomen gets larger in pregnancy. And so that's going to pull these forward, right? So a lot of times in this 3rd trimester pregnancy, we see the thoracolumbar junction starting to accumulate a little tension and stuckness. And we like to work with that. A couple more deep breaths here. Beautiful. Okay, we're going to take a moment to check hip range of motion and make sure that that is good. So what we're looking for is patient's prone, lifting the foot just a little bit, and it's just a simple in and out. So the ball is rotating in the socket as I do this, and I want that to feel smooth, and I want the end range to feel springy. So if the end range feels really blocked, abrupt, and there's no flexibility to it, there's something going on, probably in the deep hip rotators. So now I've got my thumb directly on the ball and socket, and I can really feeling it gliding in there, and it feels really smooth. So if it feels smooth, full range of motion, nice end range, I'm happy because the hip is happy. So here I've got a couple fingers on the SI joint, and I'm going to lift her foot and jiggle it a little bit. And you see that movement happening right there in the SI joint. That's the way that I like to just initially get a sense of what that SI joint is doing. Hers is moving beautifully. So let's test the left side. Same idea. Nice. Good. I'm going to bring this knee out just a little bit. So that ball and socket is going to be in its most open and easy position with the knee out from midline just a little bit. And that's where we want to test it. Yeah. Nice range of motion. Nice springy end feel. Here's her SI joint right under these two fingers right here. Lift and jiggle. Everything's moving really, really well. Wonderful. I am optimistic for you. Lift your tummy if you can. Good. Do you need a break?
No.
Good. All right. We're going to loosen up her shoulder girdle. And so I've got my knee here covered in the towel. Her elbow is just resting on it. And I can take my hand and cup the anterior deltoid and the head of the humerus. And I can, so I'm like taking all the weight of her arm pretty effortlessly. And I can start to mobilize her scapula, feeling where it's a little bit stuck right here on the left side on the lower scapula. And because this isn't an injury or a long-standing pattern, this shouldn't be difficult to work through. She's just noticing the shape of her body changing and her arms having to make some adjustments in order to accommodate that. And that's, you know, there certainly are complicated pregnancies in the world, but even uncomplicated pregnancies are a little bit complicated because of how much the body changes. And this day and age, it's really common for stress and fatigue to be a pretty big part of it as well. So I like to be here to help with those things. As far as contraindications, the main things you need to keep in mind are number one, that the ligaments of the whole system will start to get a little bit lax toward the end of pregnancy because the relaxant is in there. So you want to be careful about how much movement you put through joints. It's really good to be educated about early signs of complications with pregnancy because as a chiropractor, I probably will see my pregnant patients every 2 or 3 weeks of their pregnancy. And so sometimes I'm the first person to ask or notice when something starts going wrong. So it's good to be educated about that. Positioning is a really big one. One of the things I really like about this table is that it's comfortable for pregnant women. And it's nice if you can have props and things for them to be able to lay prone. And then otherwise, if you can't do this, you can do all of your work side lying, and most pregnant women are perfectly happy to lie on their side as long as you need. I'm going to come around the other side. Okay, same idea on the other side. Gentle traction here with my knee and support there and get some mobility going here. It's a nice breath. Good. So the stretch that's happening here is I'm pulling her humerus directly toward my center and getting some space in the shoulder girdle and just kind of gently encouraging that movement on the scapula with these fingertips here, just like that. Beautiful. Okay, thank you, Elle. Thanks for watching.